and then we'll be okay.
So the third stage of labor is the period following the complete delivery of the newborn until the complete delivery of the placenta. And it usually lasts no more than 30 minutes, usually somewhere between 10 and 30 minutes. If it does last longer than 30 minutes, it's considered to be prolonged. If the third stage of labor lasts longer than 18 minutes, there is an association with an increased risk for postpartum hemorrhage. And if it lasts longer than 30 minutes, there's a six-fold increase of postpartum hemorrhage. Next slide, please. You can see on this slide that there are several complications that are listed to the third stage of labor, and some of those seem pretty intuitive to us, such as anemia. This could cause weakness, fatigue, feeling really bad after delivery, but it also can cause prolonged hospitalization, and some of the things that we may not worry about, but the mother would, is sort of putting off the establishment of breastfeeding between the couple. We can give the mother treatments. We can give blood transfusions to ameliorate the anemia and shorten the hospital stay, but we all know that there are complications that go along with blood transfusions as well. Along with that also is that if we need some anesthesia or if we need to take the patient to surgery, there are complications from anesthesia and also an increased risk of sepsis. And it is important to note that 20% of our patients that develop postpartum hemorrhage and complications have no risk factors. So if you'll go to the next slide, we'll look at those risk factors. Each patient, since there are 20% who do not have risk factors, should be observed for postpartum hemorrhage after every delivery. Next slide, please. So what is the physiology that makes this time so dangerous in a woman's life? Next slide. There are some things that we all know that are physiologic changes during pregnancy, and probably the one that we're most familiar with is the increase in blood volume. So by term pregnancy, the maternal blood volume increases by about 50%. And we know that the plasma volume increases more than the red blood cells, so this leads to a physiologic anemia of pregnancy. There's a good reason for this to occur during pregnancy. This increased volume serves to fulfill the perfusion demands of the low-resistance uteroplacental unit, and it also provides a reserve of blood for the delivery. It also protects against the hypotension that's caused by decreased venous return, in other words, a hypotensive effect that we see early in pregnancy due to the high progesterone levels. The second listed on this slide is the increased blood flow. We know that the initial growth of the uterus and the ultimate growth of the placenta requires that there is an increased blood supply and an increased blood flow. And in fact, at term, there is an estimation of a blood flow of 500 to 800 milliliters per minute of blood flow to that uteroplacental unit. This represents about 10 to 15% of the total cardiac output. Changes in the coagulation system also occur during pregnancy. There is a marked increase in the clotting factors and a decrease in the fibrolytic activity. So the platelet count may actually fall slightly during pregnancy. This is due to the dilution with that increased blood volume, and it also is a result of low-grade consumption. However, the individual platelet count actually increases during pregnancy, and the activity of that system is maintained. Next slide, please. This is just a picture that I found on the internet that sort of explains placental separation. Following the delivery of the fetus, uterine contractions continue and the placenta is really sheared from the wall of the uterus. As the surface area of the placental site reduces, the uterus shrinks. And when it shrinks and decreases in size, it causes a myometrial retraction. And one of the unique things about the muscles of the uterus is that as they contract, they maintain that shortened length following each successive contraction. When this happens, the placenta is undermined, it detaches, and then it is propelled into the lower uterine segment. As it detaches, the spiral arteries are exposed to the placental bed, and if we didn't have sort of these protective mechanisms in the uterus, massive hemorrhage would occur. The vessels that supply the placenta bed traverse a latticework of muscles in the uterine wall that crisscross, and as the muscles contract, they have sort of a tourniquet effect to these vessels. They're sometimes referred to as living ligatures or physiologic sutures of the uterus. Now, we know that there are several drugs that we give after delivery that can cause an accentuated effect of these muscular contractions. However, we do have to realize that some of the medications that we give during pregnancy, such as nifedipine or mag sulfate, will cause these muscles not to contract as well. So we have to be wary of that in deliveries of patients who are receiving those medications. Next slide, please. During the second half of the 20th century, a package of interventions performed during the third stage became the cornerstone for prevention of postpartum hemorrhage, and they were referred to as the active management of the third stage of labor. Prior to that, we managed the stage of labor with expectant management. And you can see on the slide the differences in those two ways of managing that third stage. When I was in school, we were taught to recognize the stages of, or the signs of placental separation, and it was kind of a wait and see type thing until the placenta was delivered. No uterotonic drugs were given prophylactically. I've been through several times during my career where the cord was clamped early and then it was clamped late, or the cord was milked and so forth. And the placenta was mainly delivered by maternal efforts and nothing more. When the active management became popular, we found that it was beneficial to administer uterotonic drugs within the first minute of the baby's birth. The cord was clamped and cut at about 2 to 3 minutes, and that was called prolonged waiting to cut the cord. And then controlled cord traction with counter pressure was introduced. Next slide, please. 2 important trials have demonstrated that active management of labor provides several benefits to the mothers. These are listed on the slide. So there is a decreased incidence of postpartum hemorrhage by about 60%. There's a decreased length in the third stage with no significant increase in cases of retained placenta. And there is a decrease in the percentage of third stage of labor that lasts longer than 30 minutes. There also has been shown a decreased need for blood transfusions and a decreased need for uterotonic drugs to manage postpartum hemorrhage. And in fact, several studies that are listed in the Cochrane Library show that the active management results in a reduction in the average risk of maternal primary hemorrhage of greater than 1,000 milliliters at birth, and a decrease in the number of mothers who have a hemoglobin less than 9 following birth. Along with that, there have been no differences found in the incidence of admissions to NICU or of infants having jaundice. Next slide, please. So when active management of labor first came out, there was some concern that there were some risk of biases when they were trying to evaluate whether it had been really beneficial to the mothers. So there was a call to look at the various components of active management of labor and to question those as whether they were beneficial or not. So evidence-based analysis has established that active management of the third stage of labor can reduce maternal hemorrhage, but studies evaluating the individual components only confirmed that oxytocin administration was effective, particularly in high-resource settings and low-risk women. So the World Health Organization decided to look at this, and in their 2012 executive summary, they stated, quote, postpartum hemorrhage is the leading cause of maternal mortality in low-income countries and the primary cause of nearly 1/4 of all maternal deaths globally. Most deaths resulting from postpartum hemorrhage occur during the first 24 hours after birth, and the major of these could be avoided through the use of prophylactic uterotonics during the third stage of labor and by timely and appropriate management, end quote. So we're going to look at those individual components and see what's been shown as the most current recommendations for the third stage of labor. Next slide, please. Based on the evidence, administering uterotonics is the most important component, and oxytocin has been referred to as the preferred drug. The benefits of the other steps are less clear. Oxytocin is the preferred drug because it is at least as effective of any of the others and has fewer side effects than methergin or prostaglandins. Active management of labor involves administering the uterotonic agent with the delivery of the anterior shoulder or with the complete delivery of the newborn. Now, when studies were done to show the difference in those two times, it was noted that there usually is only seconds between the delivery of the anterior shoulder and the delivery of the baby, so it probably doesn't matter all that much when choosing between those two times to give the uterotonic. The important thing about that, though, is that the anterior shoulder must be delivered before a uterotonic is given, because in the case of a shoulder dystocia, if the Pitocin were given to the patient prior to delivery of that anterior shoulder, it would lessen the effects of the types of maneuvers we would do to relieve the shoulder dystocia. One of the concerns was whether or not Pitocin would cause significant hypotension, and because that was a long-held view, but randomized controlled trials did show that giving Pitocin at this time did not increase the events of hypotension. When studying whether to give it IM or IV, it was noted that IV oxytocin reduced the risk by about 70% compared to IM administration, although the route of administration did have little effect or little difference if the IM dose was combined with cord traction and uterine massage. Misoprostol is one of the drugs that also has been evaluated for prevention of postpartum hemorrhage, and it is used in many places, not so much in the United States, but it's used in areas that don't have access to high-quality obstetrical care. It's less expensive, and it is heat and light stable, whereas Pitocin should be kept cool. When administering misoprostol oral or sublingual, it reduces severe postpartum hemorrhage and reduces the number of transfusions that would be needed. However, oxytocin remains the drug of choice. The side effects that we see with misoprostol that make people not want to use it are usually shivering and fever, and there is sort of a typical pattern for these side effects. Shivering usually occurs first before the fever and has an onset of less than 20 minutes postpartum. It peaks at 1 to 2 hours, and then it spontaneously declines over about 3 hours. It actually should only be used when oxytocin is not available as a first-line treatment. They also looked at oxytocin and a second-line uterotonic such as Hemorrhage or methergin, and felt that those were effective but had more side effects than the oxytocin in itself, but should be readily available in delivery rooms and ORs. So the final verdict is that the World Health Organization, ACOG, the American Academy of Family Physicians, and A1 recommend administering uterotonics after all births for the prevention of postpartum hemorrhage. Therefore, all OB facilities should have guidelines for routine administration of uterotonics in the immediate postpartum period. Next slide. The next component that we'll look at is controlled cord traction. In 2014, there were some randomized trials that compared controlled cord traction with a hands-off approach. And the results were that controlled cord traction reduces the need for manual removal of the placenta, as well as a small statistical reduction in the duration of the third stage, which that was only shown to be 3 minutes. There was a decrease in mean blood loss, but only by about 10 milliliters, and there was a decreased incidence of postpartum hemorrhage. Although the benefits of the controlled cord traction, if you look at them in themselves, do not seem very significant, they did show that there were no harms, significant harms for using this maneuver if performed gently without excessive traction by someone who had been trained to do this. So how is controlled traction done? It's called the Brandt-Andrews maneuver, and you can see on the slide there's just a graphic of what is done. The cord is grasped with one hand and gentle traction is applied while simultaneously applying suprapubic pressure with the other hand. This is not fundal pressure. It is where the hand that is not holding the cord pushes down on the suprapubic area and upward towards the patient's head. It should only be done in a well-contracted uterus, so it's not something that can be done immediately after delivery of the baby. You have to wait for the uterus to contract before it can be done. Now, the benefit of doing this is that it's important that the placenta be removed quickly once it has separated from the uterus, because if it's not removed, then the uterus may not be able to contract very efficiently. The counter traction helps prevent uterine inversion. Next slide, please. Delayed cord clamping was another component of the active management. And ACOG, in the 2017 committee opinion, as you see on the screen, recommends delayed cord clamping in the term and preterm infant for at least 30 to 60 seconds. This is with a vigorous infant. So the advantages, the main advantage is that when you do the delayed cord clamping, there is a higher infant iron stores at 6 months of age. This may be particularly advantageous if the mother has anemia of pregnancy, or if the mother has low ferritin levels and plans to breastfeed without supplementing with iron or fortified formula. Disadvantages would be there are some studies that have shown a slight increase in hyperbilirubinemia in the immediate newborn period for these babies. And also, delayed cord clamping may reduce the volume of umbilical cord blood available for harvesting stem cells. So that might be something to think about if you have parents that want to do that. The main thing is that delayed cord clamping should not interfere in the timely care of a newborn or a mother who are compromised. So an example would be if there was an abruption or a cord avulsion or something like that, then the cord should go ahead and be clamped and cut immediately. It also may not be appropriate in cases of fetal growth restriction with abnormal umbilical artery Doppler flows, because these newborns may already have polycythemia or hyperviscosities. Now, in our hospital, the only part of this that we have started routinely is to do the delayed cord clamping with our preterm babies and mothers who request the delayed cord clamping. So all of our babies that we expect to go to the NICU, unless they are in distress, they have delayed cord clamping until after 1 minute. In a 2018 systematic view of babies, preterm babies, they looked at babies whose cords were clamped greater than 60 seconds after delivery and those that were cut immediately or at less than 10 seconds. And they found that the delayed when it was safe to do this, and they looked at the two time periods, there was a reduced neonatal hospital mortality by approximately 30% in these preterm babies that were stable and waited later than 60 seconds after delivery. There was an increased peak hematocrit by 2.75% and a reduced proportion of infants that had to have blood transfusion by about 10%. That's pretty significant. There also was, they did find that there was an increased peak serum bilirubin by 4, but this did not increase the morbidity of these infants. And even though the delayed cord clamping didn't reduce the incidence of intubation for resuscitation, admission, temperatures, mechanical ventilation, or severe IVH, or lung disease, or onset of sepsis, it didn't increase the morbidity from these entities. So it was shown that this did not compromise the babies that did have poor outcomes. One of the reasons that it is thought that delayed cord cutting in the preterm baby would be beneficial is that it would provide more time for the physiologic transition from fetal to newborn life. So we know that approximately 75% of blood available for placental to fetal transfusion is transfused in the first minute after delivery. Delaying the clamping of the cord may increase the neonatal blood volume and improve the neonatal and infant iron stores. It also may decrease anemia in the baby and also facilitates the fetus to the neonatal, fetal to neonatal transition. One of the things that was pointed out in one of the articles that I read that was really interesting with me is that we know that one of the things that changes the fetal circulation to newborn circulation is when the baby takes the first breath and oxygen is introduced into the lungs, it causes the hypertension of the lungs to relax and there's more blood flow to the lung tissue. So if we could wait until after the baby took the first breath and this hypertension was decreased in these fetal lungs, then that means that there would be more blood volume returning to the left side of the heart for the baby. So that would increase their preload on the left side of the heart, which would be beneficial to the newborn circulation. Next slide, please. One of the other components that are included in some protocols for active management is fundal massage. And there have been a limited number of well-conducted studies to show whether massage is, very beneficial after the delivery of the placenta. But what it has shown is that if the Pitocin is given, there are very few instances where fetal massage is required. So once the placenta is delivered, the uterus may have a tendency to relax slightly, and although these uterotonic drugs help, the provider must also just check to see if the fundus is firm. Palpating the fundus and massage of the fundus are uncomfortable to the patient, so once it is determined that the fundus is firm, it should not be massaged further. And the patient can actually be taught to massage the fundus on her own. Next slide, please. So when the World Health Organization revisited the components, they made some adjustments to their recommendations, and I'm just going to tell you a summary of some of the most important ones that have to do with the third stage of labor. They determined that all women should receive uterotonic drugs during the third stage of labor. It could be oxytocin IM or IV, but oxytocin is the drug of choice. If it is not available, in some countries it's not, then misoprostol is the second line that is recommended. They determined that controlled cord traction is now regarded as optional in settings where there are birth attendants, but it only should be used when there has been a skilled attendant who has been trained to do that. Early cord clamping is generally contraindicated, but of course, again, if the baby is in trouble or the mother is in trouble, then it needs to be done. Continuous uterine massage is not recommended as an intervention to prevent postpartum hemorrhage in women who have received prophylactic oxytocin. However, surveillance of uterine tonus through the abdominal palpation is recommended in all women for early identification of postpartum uterine atony. They also recommend that oxytocin be used after a C-section, and that during C-section, cord traction is recommended as preferred to manual removal when assisting in the delivery of the placenta. They recommend that if the third stage lasts longer than 30 minutes, controlled cord traction and IV oxytocin should be used to manage the retained placenta. If the placenta is retained and bleeding occurs, manual removal of the placenta should be expedited, and when that happens, there should be a single dose of prophylactic antibiotics. The next slide, please. This is the last slide. Prevention of postpartum hemorrhage is always much better than treating postpartum hemorrhage, and the best preventive strategy is a risk assessment and active management of the third stage of labor. And these recommendations come by ACOG, the International Federation of Gynecologists and Obstetricians, International Confederation of Midwives, and World Health Organizations. Thank you.
Thank you, Judy. We really appreciate